Thank you for the opportunity to be here today. My name is Michael Leapman, and I'm a urologist at the Yale School of Medicine in Connecticut. Today, I have the privilege to speak with you about patterns of utilization and disparity in prostate cancer risk assessment tools. These are my disclosures. The risk assessment paradigm for localized prostate cancer has evolved substantially in the past decade. Notably, clinical advancements have occurred through the refinement and availability of disease biomarkers across the spectrum of the disease, including diagnosis, initial management, secondary therapy, and post and beyond, including a suite of blood and urine-based biomarkers, gene expression tests, germline, and next-generation tumor testing. Each of these modalities have shown promise in impacting and generally enhancing prostate cancer care. For the purpose of our talk today, I hope to focus on a few of these tests, focusing on imaging tools in particular, prostate MRI, PSMA PET, and molecular imaging, as well as commercial gene expression testing. Given the promise of these tools and their ability to affect prostate cancer outcomes, there's a timely opportunity to take stock of how testing has come to be used in the real world practice today and focus primarily through the lens of the United States healthcare system, but also give thought to how variation in testing may impact clinical care more broadly. In our time today, I plan to cover national uptake, time trends in the adoption of these tests, focus on effects of regionalization and determinants of testing, and talk about sociodemographic disparity, particularly racial disparity. And lastly, go over the potential impact of variation in testing on treatment and outcome. So on the heels of strong evidence for improved prostate cancer detection, there has been rapid uptake in prostate MRI in the pre-biopsy setting. In this analysis of commercially insured and Medicare Advantage patients in the Optum Real World database, the unadjusted and age-adjusted rates of MRI at the time of biopsy markedly rose from 7 per 1,000 biopsied patients in 2010 to 74 in 2016, a nearly tenfold rise, with continued rises occurring in all healthcare markets. However, it's worth noting that these estimates are still lower and suggest that full saturation has not occurred in the US market by any means, and are sharply contrasted by the experience in the UK, where in 2018, 86% of surveyed UK areas reported they provided some form of MRI before biopsy in their area. When looking at patients with a diagnosis of prostate cancer, current estimates also show brisk uptake of both MRI and tissue-based gene expression testing. Among commercially insured beneficiaries with Blue Cross Blue Shield insurance, we performed a dynamic cohort study to evaluate patterns of testing in the period preceding and following prostate cancer diagnosis, and found that MRI increased to 16.7% of patients diagnosed in 2019. Similarly, genomic testing using claims for commercially available gene expression tests, Oncotype, Prolaris, and Decipher, increased to 12.7%. In these analyses, no restriction was made to patients with localized disease, importantly, based on the use of only administrative claims. And therefore, it is likely that the proportion of genomically tested patients is higher among those with localized disease who are ostensibly candidates for local therapy or active surveillance. Although uptake of prostate MRI and genomic testing has increased, it is also clear that the pace of adoption is highly varied in the US, consistent with well-described patterns of regionalization in healthcare. In a study of 65,000 patients with prostate cancer, use of MRI increased significantly between 2012 and 2019, but varied substantially by hospital referral region. Here we can see the extent to which practice varies by region, with darker areas showing greater change in the use of prostate MRI and several areas with minimal change or uptake over time. Variation in the use of genomic testing is also evident. And in commercially insured patients with prostate cancer, we similarly characterize HRR level variation in the use of genomic testing in the period surrounding prostate cancer diagnosis. So in this study of 92,000 beneficiaries with prostate cancer, use of genomic testing increased from a negligible baseline in 2012 to approximately 11.3% of patients diagnosed in the 2017 to 2018 period. Pronounced sociodemographic disparities in prostate MRI are also evident. Among Medicare beneficiaries in SEER, patients residing in the Midwest had a five-fold lower odds of prostate MRI use compared with those in the Northeast. In addition, those residing in large metropolitan areas had a higher odds of undergoing a prostate MRI compared with metropolitan areas. Observational studies have consistently shown lower odds of prostate MRI use among patients whose race was identified as Black versus white or others. In SEER Medicare, non-white patients were less likely to undergo prostate MRI in the period surrounding diagnosis. Furthermore, an insurance claims-based study showed that Black, Asian, and Hispanic patients were less likely to undergo prostate MRI as compared with white patients. These differences were more pronounced among those with higher PSA levels. Black, Hispanic, and Asian patients with PSA levels greater than 10 were 35%, 23%, and 26.7% less likely to undergo a prostate MRI compared with white patients. Yet it is insufficient to ask the question, does disparity exist? In addition, we must also consider what are the sources of disparity and how can they be addressed? To help understand the factors underlying an observed 40% lower odds of prostate MRI use in Black versus white patients, we sought to explore the following conceptual model. Do intervening factors or mediators exist that can explain the observed association between race and prostate MRI? And we selected 4 categories of potential mediators, those relating to clinical and pathologic factors, socioeconomic status, geography, and racialized residential segregation. What we found is that among Medicare beneficiaries in SEER, nonlinear multiple additive regression tree analysis was used to quantify the role of these mediators. And in the sample of over 39,000 patients with prostate cancer, our analysis was able to account for 81% of the observed racial disparity attributable to assessed mediators, including 24% to geographic differences in neighborhood economic status, 19% to racialized residential segregation, and 11% to dual eligibility for Medicaid, a marker of socioeconomic status. In parallel, there have been tremendous advancements in recent years with the integration of molecular imaging, notably PSMA, prostate-specific membrane antigen PET. These agents have been recently approved in the United States at the end of 2021 for widespread utilization outside of the initial approvals that were confined to 2 medical centers. But little is known about national patterns of PET utilization. We conducted a serial cross-sectional study to evaluate use of PET imaging among insurance beneficiaries aged 40 to 89 with a diagnosis of prostate cancer. We used de-identified administrative claims from Blue Cross Blue Shield and included eligible participants with a diagnosis of prostate cancer on claims, including prevalent and incident prostate cancer cases. And what we found was that the use of PSMA PET-based tracers increased significantly following wider approval of these agents at the end of 2021. It's quite striking to see the inversion of trends with cyclovine used and rising among individuals with prostate cancer, but going away essentially overnight following the approval of PSMA PET-based tracers. We also sought to evaluate regionalization of PET imaging, applying a similar model as to what we had looked at prostate MRI and genomic testing, looking at hospital referral region level variation. And in the second half of 2022, the most current year that we conducted this analysis, there was marked regional variation, an over 2-fold greater difference at the lowest versus highest quartile of utilization. And when looking at the characteristics of regions that did or did not adopt PET imaging to lesser or greater degrees, we found that areas with increased adoption of PET imaging had higher education levels, income levels when looked at in aggregate. So in conclusion, there has been rapid adoption of prostate MRI, genomic testing, and molecular imaging in the United States. Use of testing remains highly varied by patient and area level factors. Racial and sociodemographic disparities mirroring entrenched healthcare imbalances have accompanied widespread uptake and require urgent attention. Lastly, the impact of this variation on testing and clinical outcomes remains unknown and is an important area for further investigation. Thank you so much for your time and attention today.